Good afternoon, everybody. It is a pleasure to be with you here today. Thanks for the organizing committee for the invitation. Today, we are going to have a rapid overview on an important topic which we face a lot during our daily clinical practice, which is the neurological manifestations of rheumatological diseases. I know it could be a tough topic for many, but we will try to make it simple as possible. These are my disclosures. Historically, rheumatological diseases have been classified as autoimmune disorders. Nowadays, this classification is increasingly changed, and they are thought of as a spectrum of disorder with various contributions of autoimmunity, which is represented by adaptive immune dysregulation with autoimmune antibodies, and autoinflammatory denoting innate immune dysregulation with cytokine storm as a main pathophysiologic process. This new classification would have an impact on management strategies which should target specific pathophysiologic process, either with agents targeting autoantibodies or cytokine pathway or both. In this context, as a systemic disorders, rheumatological diseases could affect both CNS and BNS with varying degrees. Nervous system affection could be apart from the rheumatological disease itself as primary affection or due to complications related to the disease. Most common neurological manifestations include meningoencephalitis, cerebrovascular strokes, CNS demyelination, peripheral neuropathy, and myopathy. Let us have some clinical cases that could guide our way through this topic. This is our first case. This is a 58 years old woman with systemic lupus erythematosus. She presented with 5 days progressive asymmetric quadriparesis, incoordination, and urinary retention. She was diagnosed with systemic lupus 26 years earlier in the setting of polyarthritis, Raynaud's phenomena, immunothrombocytopenic purpura, and positive immunological studies including ANA and anti-double-stranded DNA and low complement levels. She was treated with hydroxychloroquine and steroids, which were tapered, and she remained in long-term remission for years. On examination, she had quadriparesis with pyramidal distribution of weakness, hyperreflexia, and bilateral positive Babinski sign. This is clearly a presentation with cervical transverse myelitis in a patient with systemic lupus erythematosus. So, MRI cervical was obtained. It revealed long, extensive transverse myelitis from the cervicomedullary junction till T2. This lesion has Behçet enhancement. Hair base collapse were normal, anti-double-stranded and complement were negative. CSF showed lymphocytosis with negative oligoclonal bands. Aquabrine 4 antibodies were positive. She was diagnosed as neuromyelitis optica spectrum disorder in the context of inactive systemic lupus erythematosus. She received IV methylprednisolone plus plasma exchange and recovered almost completely and was maintained on rituximab. The American College of Rheumatology has described 19 central and peripheral neuropsychiatric SLE associated syndromes. The prevalence of neuropsychiatric lupus is around 40% of patients with systemic lupus erythematosus. These could be either primary neuropsychiatric SLE or secondary to SLE-related complications as infection, metabolic derangements, or medication toxicity. Evidence of systemic lupus can be supportive but is neither necessary nor sufficient to establish a diagnosis of primary neuropsychiatric SLE. Patients with neurologic complications due to SLE process are considered to have severe disease that could need treatment escalation. These are the neuropsychiatric manifestation of systemic lupus, including central nervous system and peripheral nervous system manifestations. Regarding CNS manifestations, headache and mood disorders are the most reported neuropsychiatric syndromes, but they do not comply with disease severity, and their presence does not necessitate any intervention apart from symptomatic management. Ischemic stroke is common with frequency up to 18%. Risk factors in patients with SLE include high disease severity, the presence of antiphospholipid antibodies, prior history with neuropsychiatric lupus, and African descent. It is recommended to get antiphospholipid antibody levels in all patients with ischemic stroke and SLE. Anticoagulation with warfarin is mandatory as secondary prevention for the stroke in these patients. Both focal and generalized seizures occur in patients with systemic lupus erythematosus, and status epilepticus is common and implies aggressive management for seizure and escalation of immunotherapy. Demyelinating syndromes, primarily optic neuritis and myelitis, occur in patients with systemic lupus. They may represent a direct manifestation of lupus, but mostly they reflect comorbid neural specific autoimmunity such as neuromyelitis optica spectrum disorder. Recently, lupus myelitis is divided into two phenotypes, gray matter pattern, which is characterized by flaccid myelitis and associated with prominent systemic symptoms and has anti-MOG antibodies, and a white matter pattern with spasticity and hyperreflexia, usually associated with aquaprine 4 antibodies. Steroid-responsive aseptic meningitis with or without associated meningeal enhancement is also common. Chorea is a rare manifestation of lupus, primarily in patients with antiphospholipid antibodies. Peripheral nerve complications occur in up to 14% of patients with SLE. Sensory axonal polyneuropathy are the most common, followed by small fiber neuropathy. Also, vasculitic neuropathy as neuromyelitis multiplex occur. Symptomatic management in these patients is the mainstay of therapy, except in patients with vasculitic neuropathy, in which cases high-dose corticosteroids and cyclophosphamide should be administered. Our second patient, 61 years old woman, developed numbness in her hands, followed several months by gait instability and hand clumsiness. She continued to decline over 2 years and ultimately required a cane for ambulation. In systemic review, she endorsed sick symptoms in the form of dry eye and dry mouth, with frequent visits to the ophthalmologist, but denied any orthostatic lightheadedness or bladder or bowel dysfunction. Examination showed no weakness, but reflexes in the upper and the lower limbs were absent. There was vibratory sensory loss in both lower limbs, and joint position sense was absent up to the knees, and rheumatic test was positive. This is clearly implies all sensory modality affection, which was confirmed by nerve conduction study, which showed absent sensory nerve action potentials with preserved compound motor action potential. Neuroimaging brain and spine were normal. Hair labs showed positive anti-Ru, anti-La antibodies, negative ANA and anti-double stranded. CSF examination was normal. Taking in consideration that this patient could be Sjögren syndrome, her lip biopsy showed lymphocytic cell adenitis, which confirmed the diagnosis of pure sensory neuropathy with sensory ganglionopathy in the context of Sjögren syndrome. Estimated frequency of neurological involvement in Sjögren syndrome are found around 16% for peripheral nervous system and 4% for central nervous system. Serologies as anti-Ru, anti-La antibodies are of limited sensitivity and specificity. Measures of exocrine gland dysfunction as Schirmer test or salivary gland biopsy demonstrate lymphocytic cell adenitis and can help in establishing the diagnosis. Primary sensory neuropathies including dorsal root ganglionopathy and small fiber neuropathy are common in Sjögren syndrome. Vasculitic neuropathy can also occur and is usually associated with extraglandular features, cryoglobulinemia, and hypocomplementemia. Other types of neuropathy could also rarely occur as sensory-motor polyneuropathy, autonomic neuropathy, and trigeminal neuropathy. Nerve conduction studies usually assess large fibers, so they are usually normal in cases with small fiber affection. Skin biopsy assessing epidermal nerve fiber density can confirm the presence of small fiber neuropathy. Small fiber neuropathies are managed primarily symptomatically. Dorsal root ganglionopathy tends to be refractory to immunotherapy. Mononeuritis multiplex was reported to respond to high-dose corticosteroids, rituximab, or cyclophosphamide. Unfortunately, no randomized placebo-controlled trials of immunotherapies in Sjögren syndrome have been conducted. Regarding CNS manifestations of Sjögren syndrome, demyelinating syndrome have been reported in association with Sjögren, especially neuromyelitis optica spectrum disorder. This association likely represents an overlapping autoimmune syndrome rather than a manifestation of Sjögren. Rare cases of recurrent meningoencephalitis also have been reported. Cyclophosphamide has been used in refractory cases for patients with aquaporin 4 antibodies. Rituximab is usually used as a steroid-sparing agent. In cases with aseptic meningitis, short course of oral steroids can be considered. Our third patient is a 48-year-old man which has been battling rheumatoid arthritis for the past 7 years. He has been under treatment with various disease-modifying medications to manage his joint symptoms. He was recently started on anti-tumor necrosis factor alpha. Despite stable control of his rheumatoid arthritis, he presented to the hospital with severe headache, neck stiffness, and episodes of confusion over the past few days. On examination, he has signs of meningeal irritation in the form of meningeal irritation signs, and he was confused with disorientation to time, place, and person. He had also low-grade fever. The patient has long-standing history of recurrent neck pain with pain radiating to the right ear with multiple visits to orthopedic clinics. This patient with high suspicion of meningitis saw CSF analysis showed elevated neutrophilic count, high protein levels, normal glucose, but in hair cultures were negative, excluding septic meningitis. Also, septic workup was negative. His MRI brain showed unilateral leptomeningeal enhancement, as we see here. MRI cervical spine showed soft tissue proliferation around the dens with some mass effect. Tumor necrosis factor alpha inhibitor was stopped. Patient received IV methylprednisolone for 5 days and his symptoms improved apart from neck pain and limited mobility. He was referred to neurosurgery for follow-up of the cervical myelopathy. This patient shows a case of tumor necrosis factor alpha inhibitor induced aseptic meningitis in a patient with rheumatoid arthritis with cervical canal stenosis due to venous formation. The most common CNS manifestation in rheumatoid arthritis is the cervical spinal canal stenosis due to synovitis and venous formation at the atlantoaxial, atlanto-occipital, or subaxial level. Early use of biologics in these patients can improve the prognosis. Aseptic meningitis is rare but well documented. It is more common in patients with long-standing seropositive disease and frequently occur in absence of significant systemic disease activity. Some patients also who receive tumor necrosis alpha inhibitor could develop aseptic meningitis after initiation of treatment. In these cases, discontinuation of the medication will help to improve the symptoms. Entrapment neuropathies are likely the most common symptomatic peripheral nervous system manifestation in patients with rheumatoid arthritis. Our fourth case is 72 years old woman presented to her primary care physician with complaints of severe headache, tenderness over the temple, and sudden visual disturbance. She reported having fatigue, jaw pain while chewing, and an unexplained recurrent low-grade fever for the past few weeks. Concerned about her symptoms, her doctor examined her and found temporal tenderness and swelling, along with decreased visual acuity and episodes of transient visual obscurations. Suspecting giant cell arthritis, he ordered ESR and CRB. They were elevated. Then she underwent temporal artery Doppler, which showed halo sign, and temporal artery biopsy confirmed the diagnosis. It showed narrowing of the lumen with intimal hyperplasia, breakdown of internal elastic lamina, infiltration by giant cell, and she was diagnosed as giant cell arthritis. She received IV methylprednisolone and was tapered on oral steroids with improvement in her symptoms. Headache occur in more than two-thirds of the patients with giant cell arthritis, and nearly half of the patients complain of jaw claudication. Transient monocular visual loss can occur early in the disease and is harbinger of permanent visual affection. Diagnosis of giant cell arthritis should be confirmed by temporal artery biopsy. When it is negative, contralateral artery biopsy should be obtained. Also, in some cases with negative biopsy, imaging of large vessels with CT or MRI angiography may identify large vessel vasculitis and can be useful in patients with suggestive symptoms but negative temporal artery biopsy. Once giant cell arthritis is suspected, oral steroids should be started regardless of the confirmatory test results. Our fifth case is a 68 years old man who awoke with new onset right arm pain and numbness of his right fourth and fifth fingers. This patient had a previous long-standing chronic rhinosinusitis associated with otitis media resistant to medical treatment. With his right arm pain and numbness, he also had numbness over the lateral aspect of the right foot and right foot drop. On examination, the patient showed weakness of the right thumb adduction and fourth and fifth finger flexion, weakness of right foot dorsiflexion and eversion, hypothesia over the dorsum of the right foot and right lateral calf, bilateral ankle hyporeflexia, and bilateral downgoing plantar. This is clearly a case of mononeuritis multiplex in which there is affection of a single nerve in different limbs with which affect sensory and motor modalities. Nerve conduction studies showed right ulnar and peroneal mononeuropathies, sensory and motor. CRB was elevated. ANCA was positive. Other labs, including renal function test and urine analysis, were negative. CT chest was normal. Nasal endoscopy showed bilateral casting and beefy mucosa. And finally, right sural nerve biopsy confirmed the diagnosis and demonstrated epidural nerve arteriole necrotizing vasculitis. He was diagnosed with ANCA-associated vasculitis, initiated on IV methylprednisolone and kept on oral steroids and rituximab. Neurological involvement in these patients occur in up to 70% of patients, with peripheral nervous system being primarily affected. CNS involvement occur in 15% of patients. Peripheral nervous system involvement often manifests as mononeuritis multiplex, which evolves in subacute manner. Other patterns include plexitis and subacute distal sensory motor polyneuropathy could also occur. Meningitis is the most common central manifestation, with headache and cranial neuropathy as main presentation. Mepolizumab, a monoclonal antibody targeting interleukin-5, involved in eosinophil maturation and proliferation, has been recently approved for the treatment of eosinophilic granulomatosis with polyangiitis, which is a part of ANCA-associated vasculitis. Our last case is a 35 years old man presented to the neurology clinic with episodes of severe headache, double vision, and unsteadiness while walking. for the last 6 months. These neurological manifestations have been progressively worsening, affecting his daily activity and work. He had also a history of recurrent orogenital ulcers and occasional skin lesions over the past few years. On examination, he showed signs of bilateral abducent nerve palsy leading to his double vision. He also displayed cerebellar ataxia with uncoordinated movements and difficulty maintaining his balance. The MRI brain showed hyperintensity 2 lesions affecting bilateral basal ganglia and the brain stem, which enhances on contrast. His laboratory workup showed high ESR and pathology test was positive. He was diagnosed as Behçet. He received IV methylprednisolone and was maintained on oral steroids and azathioprine with improvement in his symptoms. Neurologic involvement in Behçet is more common in males and occurs in around 5 to 10% of patients and can occur in conjugation with or precede the onset of other systemic manifestations. It can present with parenchymal disease or as a vascular syndrome. Parenchymal disease typically presents as a subacute progressive brainstem syndrome with or without encephalopathy, headache, or sphincteric dysfunction. MRI brain usually show enhancing lesion affecting mainly brainstem, basal ganglia, and cerebellum. The vascular subtype typically presents with cerebral venous sinus thrombosis and is frequently associated also with systemic venous thrombosis. Our take-home message coming to an end. Rheumatological diseases involve both autoimmune and autoinflammatory mechanisms. Neurologic symptoms can be the first manifestation of these disorders, and familiarity with the systemic manifestations of a specific disease is essential to establish the correct diagnosis. Knowledge of the neurologic syndromes that are most likely to be associated with specific systemic rheumatological disorder can be helpful to narrow the differential diagnosis. These are my references, and thank you for listening.